Once again, good afternoon. So I heard a lot of things about EEG, monitoring of ICP, monitoring of with a means of TCD, NIRS, but they are essentially used and evaluated in brain injured patients, and I don't know if we can or if we have to apply these tools in medical ICU patients. Maybe Fabio has an idea, but for the moment we do not use any of these tools in our ICU, medical ICU. Okay? And so why doing a neuromonitoring? Of course, for detecting acute brain dysfunction. But what is an acute brain dysfunction? Some are obvious: coma, delirium, seizure, focal neurological sign. But what about anxiety? What about neuroendocrine and neurovegetative systems? I showed you yesterday that it's a very important brain response to stress. What about pain? What about dyspnea, which are also controlled or integrated by the brain? What about sleep? What about dream? We can, if we like Freud, maybe the content of dream, what the patient is doing, maybe has a particular impact on the outcome. So I think that this is only to be provocative, but I think that we need to better define what is an acute brain dysfunction, or what are the functions of the brain that we have to monitor. And there are multiple. So I would like to, Jean-Louis Vincent asked a very important question about sedation. And it's true that we have to discontinue the sedation as soon as possible in our medical ICU patient, but sometimes we cannot. And patients require sedation. And they require also to be monitored in terms of detection of acute brain dysfunction. So we were asking whether neurological examination of sedated patients was useful or not. So we did in all neurological ICU patients the same examination that I have proposed you this morning about COMATOSE patients. We have ourselves the eyes response, the motor response, and we have ourselves also the brainstem responses. In all ICU patients who require sedation with midazolam and subfentanyl, we have found that there is a good correlation, reproducibility of this neurological examination. And we have included, in fact, 144 patients in two different historical cohorts. These patients were absolutely coherent of medical, consistent with the ICU medical ICU population, the mortality range. I don't know. Do you have the? It is the pointer. Yeah, it's here. So the duration of sedation was about 5 days, and the prevalence of altered mental status or acute brain dysfunction was about 57%, consistent with the data of the literature, and the mortality rate about 30%. What we found is that in most sedated patients, blinking to strong lights or eye movements or oculocephalic response were abolished, but other reflexes like the corneal reflex or the cough reflex or the grimace were quite preserved in our sedated patient with midazolam and subfentanyl. And what was interesting, in fact, and we are currently confirming this result, is that there are some reflexes, brainstem reflexes, who are highly associated. They are present together or abolished together. And it is the case of a grimace to painful stimulation of the jaw and of a cough reflex. They are abolished together or absent together. And when it's not the case, as is in this patient, this patient was referred to our ICU for a very severe RDS. He required a heavy sedation. He was comatose without any brainstem reflex. We discontinued the sedation. He recovered cough and oculocephalic response, but not corneal reflex and not grimace. So a discrepancy, between the presence of recovery of cough reflex and persistence of abolition of grimace. We did an MRI, and this is what we found: lesions of the brain. And what also we found is that the absence of cough reflex within the 12 and the 24 hours of sedation was a predictor of mortality, even when adjusted to SAPS-2. And this relationship between the absence of cough reflex and mortality was also found after D1 of sedation. And what we found also is that the absence of oculocephalic response was associated with the occurrence of delirium after discontinuation of sedation. And this, because of these results, we say that maybe there is a brainstem dysfunction in our critical ill patients. And I think that we have data supporting this hypothesis. First, cough reflex maybe reflect an alteration of the low part of the brainstem, which is the medulla, where are the cardiovascular and the respiratory centers. And we know that in our septic patient, but also in our critical ill patient, there is an alteration of a sympathetic output or control of the cardiovascular system, which has been, assessed with studying the heart rate variability. And we know that there is an alteration also of the sympathetic nervous system or the autonomic nervous system of the immune response. And maybe this explains why we have such a relationship between cough reflex and death. And what about the oculocephalic response? We think that it's a marker of an alteration of the activating ascending reticular system, because we know that the oculocephalic response is integrated in this substance, which play a very important role in arousal. And we know that some nuclei, and especially the locus coeruleus, which is a nuclei of this reticular activating ascending system, is liable to apoptosis. And we know that dexmedetomidine, for instance, protects the locus coeruleus from apoptosis and also reduce the incidence of delirium in septic patients. So I think that we have arguments for this hypothesis, and we have currently started a project in which we will assess clinically, but also with help of EVOC potential, the brainstem in all critical ill patients who are either delirious or either comatose. So I think that I try to show you that in non-sedated patients, but also in sedated patients, you have to do a neurological examination, and then upon what you find clinically, you have to decide or not to do a brain imaging, an EEG, or to check, of course, the biochemistry disturbances or the effect of drugs. I will go through this slide because I'll show you just 3 examples. This is a patient that I showed you this morning, a patient who was sedated for an ARDS. My medical students check every day the tendon reflexes. He came to me and said, oh, there is an abolition of a left reflex. I said, this is not good. This is a focal neurological sign. We did an MRI, we show a stroke. This is a patient sedated for a very heavy, very severe ARDS, and then the tendon reflex became very brisk. We did an MRI, hemorrhage. And the patient died. He never waken up. And sedation is also good for predicting critical illness neuromyopathy, which is known to be associated with bad outcome. And we have found that the abolition of tendon reflex is associated with the occurrence of ICU acquired paresis. And there are 2 explanations. First, early abolition of tendon reflex maybe reflect the effect of sedation on the alter reflex arcs. And later, abolition of tendon reflex is maybe a marker of an ongoing critical illness neuromyopathy. And this can explain why there is such a relationship with the occurrence of ICU acquired paresis. So delirium and agitation, we know that it's very current in ICU patients. And if we look at the agitation, its prevalence is about 52%. Its main risk factors is sepsis and also age. And we know that it is associated with various complications. I will go through it very quickly. And we can decrease this complication of critical illness and stay in ICU by a proper and appropriate detection and treatment. What about delirium? You know, delirium is an acute brain dysfunction which is characterized by an alteration of consciousness, an alteration of cognitive function, and it happens very acutely, and it is characterized by fluctuation, and it has a medical cause. It is related to medical causes. We know that the incidence of delirium varies according to the definition, but also to the population study, and its incidence can range from 20% up to 80%. We know that it can happen at any time of ICU stay, but especially during the first day of stay in ICU. And we know that it can be associated with agitation or without agitation, and it is associated with increased mortality. And it's related to a very complex pathophysiology. I think that it's not the purpose of this presentation, but we know that it's also associated with cognitive decline. And then I will ask you a question about the picture that I show you, the different movies. Okay, if you have well followed the presentation. And there are many differential diagnoses, of course, but what is the main feature of delirium is this fluctuation, the alteration of consciousness, and the alteration of attention, which distinguish it from other conditions like Alzheimer's disease, so dementia and psychotic disorders, or even depression. There are various scales, and that has been used for assessing sedation or agitation, or for assessing delirium. The most used is maybe the COMATOSE, but it has been recently shown that maybe it doesn't have such high sensitivity, a very good specificity and not such a high sensitivity. You can use the Cadenian score, which is very good, I think, more complete, more exhaustive than the COMATOSE. And I will go through this very quickly. And there are various risk factors on which you can try to act or behave, I don't know, to control, like hypertension, sepsis, metabolic disturbances, or drug overdoses. So just a case report, because I think that it is very illustrative. This patient was hospitalized in our ICU for a thrombotic microangiopathy. She had, in fact, a lupus, which was treated with steroids and immunosuppressive agent. And she was treated with plasma exchanges, and she had an hematoma of a thigh. And she developed a hyperactive delirium. You know, sorry, there are some French in this slide. There is some French. But she was saying, on me vole mon enfant, les médecins me volent mon enfant. It means that the physicians are taking my baby away, In fact, we did a CT scan, and she had a big hematoma of the pelvis. So just listen what the patient said. Sometimes she's saying the truth. Even if she is confused, she feels something. Just be careful in the interpretation of what the people say, or the patients say, when even they are confused and delirious. What about anxiety? Our patients are anxious. And we have just finished a study and submitted. You know, we are looking after patients with Guillain-Barré syndromes, and we know that the main complication of Guillain-Barré syndrome is respiratory failure. And so we have, at admission, assessed the anxiety of this patient. And we try to see whether it is correlated with the occurrence of respiratory failure, and so we included 110 patients. 25% of them require mechanical ventilation at least 24 hours after admission. And what we found as the main predictors of respiratory failure was the feeling of uncertainty. Yeah. Even with adjustment to motor deficit and vital capacity, or the time between onset and admission, which are the main predictors of respiratory failures in patients with Guillain-Barré syndrome. And we know, as I told you, that anxiety is a major component of the response to stress. And so we do not have to think of anxiety as something spiritual or philosophical or of comfort. It has a physiological value, you know, and I think that we need to work more as ICU physicians on this. And we are starting a study trying to see whether or not it's associated with outcome in general critical ill patient. And what about dyspnea? What we found recently with my student, Matthew Schmidt, is that dyspnea in mechanically ventilated patient was associated with difficulty to wean the patient within the 3 days. So it's a marker of something. And so maybe, you know, it's interesting that this is another factors that is also integrated by the brain. You have to be conscious to feel dyspneic. So there are many, many tools that we can use in ICU, but I think that I'm running out of time. So I will stop here, that there are many other tools that we can use, but I think that the neurological examination has still its place, and I think that there are many, many symptoms that we have to better assess and better interpret and know what they mean, like anxiety, like dyspnea, but I think that there are many, many other things that we can work on.
Thank you.